Angina originates from Latin word angere, which means to compress, and pectoris is derived from pectus, which means chest. Therefore, angina literally means compression of the chest, which actually holds significant meaning as angina is caused by decreased blood flow to the heart muscle, resulting in ischemia of the heart muscle leading to excruciating chest pain as if the heart is being squeezed. Stable angina or chronic angina is the most common type of angina, and usually occurs when 70% of the artery's lumen is blocked by atherosclerotic plaques. This narrowing allows enough blood supply to the heart at rest, but during times when the body demands more blood and oxygen, such as during physical exercise or stressful situations, the heart works harder and thus requires more blood and oxygen. It is at these moments of stress or emotional strain that individuals with stable angina experience chest pain, as the blood flow does not meet the metabolic needs of the heart muscle or myocardium. However, after rest, the pain usually subsides. In most cases, the main cause of stable angina is atherosclerosis of one or more coronary arteries, which supply blood to the heart muscles. Other heart conditions that can lead to stable angina are those that cause thickening of the heart muscle wall, requiring more oxygen due to the increased muscle size. Increased muscle size may be associated with hypertrophic cardiomyopathy due to genetic reasons, or as a result of the heart being forced to pump blood against higher pressure, such as in the case of aortic stenosis, which is a narrowing of the aortic valve, or hypertension. Larger and thicker heart muscles require more oxygen, and if the heart cannot meet the growing demands, individuals may experience angina-like pain. In any case, the heart requires blood for nourishment. Observing the heart wall reveals three layers. The outer layer is the epicardium, the middle layer is the myocardium, and the inner layer is the endocardium. Coronary arteries start in the epicardium, and then descend downward to supply the entire heart tissue. If blood flow is reduced or the myocardium is thicker, it becomes harder for blood to reach this deeper layer located just beneath the endocardium, known as subendocardium. Therefore, a classic sign of angina is subendocardial ischemia when less oxygen reaches the area directly below the endocardium. It is believed that this ischemia leads to the release of adenosine, bradykinin, and other molecules that stimulate nerve fibers in the myocardium, resulting in chest pain. Chest pain is commonly described as a feeling of pressure or squeezing and can radiate to the left arm, jaw, shoulders, and back, sometimes accompanied by shortness of breath, dizziness, or profuse sweating. Typically, the pain and other symptoms last for less than 10 minutes, on average from 2 to 5 minutes, and disappear after the cessation of stress. This is because the heart muscle no longer requires such a high amount of blood as in stable angina, where patients experience pain only during periods of exertion or stress, but not at rest. There is also unstable angina, where patients experience pain during physical exertion or stress, as well as at rest, and it never resolves on its own. Unstable angina is usually caused by a rupture of an atherosclerotic plaque with thrombosis, leading to a clot formation at the top of the plaque. Although the occlusion may not block the entire vessel, there is now less space for blood flow, and the heart tissue begins to experience a lack of oxygen even during normal activity. Unstable angina, for the same reason as stable angina, involves subendocardial ischemia and should be considered an extreme situation, as patients are at high risk of progressing to a heart attack or myocardial infarction. The key difference is that unstable angina means the heart tissue is alive but ischemic or lacking oxygen, whereas a myocardial infarction means areas of heart tissue have already started to die. Another type of angina is vasospastic angina, also known as Prinzmetal's angina, where there may be no atherosclerosis present, and the chest pain that occurs is due to vasospasm of the coronary arteries, where the smooth muscles surrounding the arteries contract intensely, reducing blood flow enough to cause ischemia. Episodes of vasospastic angina are not related to physical exertion and can occur at any time, even during rest. The mechanism underlying vasospasm is not completely understood, but likely involves vasoconstriction, such as through thromboxane A2. In contrast to stable and unstable angina, in this case, the coronary arteries narrow so severely that all layers of the heart wall receiving blood supply are affected. This is called transmural ischemia. So, by placing these three types of angina side by side, some important clinical similarities and differences can be seen. It is crucial to remember that in each case, the damage to cardiomyocytes is reversible, meaning it is not permanent, and the cardiomyocytes do not die, which sets them apart from a myocardial infarction. On an electrocardiogram, both stable and unstable angina show ST segment depression since ischemia is limited to the subendocardium. In contrast, vasospastic angina shows ST segment elevation, and for transmural ischemia, rest usually alleviates stable angina, while unstable and vasospastic angina can occur at any time, even at rest. Regarding medication, all three types can be treated with nitroglycerin, which is a vasodilator that increases the diameter of blood vessels to provide greater blood flow. Additionally, vasospastic angina also responds to calcium channel blockers. In conclusion, angina is chest pain caused by reduced blood flow leading to oxygen deficiency in the heart muscle. Three types of angina can be identified: stable angina, unstable angina, and vasospastic angina. Rest helps alleviate stable angina, unlike the other two types, and all three can be treated with nitroglycerin.